Good evening. I'm going to start tonight with a question. How often do you think about brain health, particularly the health of your own brain? Do you think about it at all? Well, I would probably suggest that it's healthy if you do so. And that's what we're going to be doing tonight. On behalf of Alpha Phi Alpha's General President, Brother Dr. Willis Lonzer III, I am Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. Allow me to introduce tonight's moderator, Alpha's Deputy Surgeon General for Mental Health, Brother Dr. Ron Kennedy Bailey. Brother Dr. Bailey is the Kathleen and John Bricker Chair, Professor, and Head of the Department of Psychiatry at LSU Health Sciences Center. He is also the Chairman of the Board of Trustees of the Cobb Research Institute and the past President of the National Medical Association. It's always a pleasure to have him moderate these panels. You will learn a lot, you will enjoy it as much as is possible, and we will empower you over the course of the next hour or so. Dr. Bailey, welcome and have a great show. I'll see you on the back end.
Well, thank you so much, Brother Sterling. I've done quite a few of these. We've enjoyed them. I think you're 100% right. They get better each time. As Brother Sterling mentioned, I'm Ron Bailey down here in New Orleans now. Very happy to be chairing our department and do as best we can to really try to improve the lives of people of all backgrounds, I think, in the New Orleans area and region, with a special focus, I think, on African-American persons and African-American men and alpha men, I think, who really deserve to have best information regarding quality access to health. We want persons to have decreased morbidity or disease throughout the normative period of their lifetimes. I also thankful to say my thanks to our General President, Willis Lonzer. Brother Lonzer has just been done a yeoman's job, I think, in pulling this program together with an idea of focusing on within the fraternity and within our community of African men on our health. So that being said, I'm proud to have been picked by Jeff Sterling to be the Deputy Surgeon General for Mental Health. I want to thank all the members, I think, of our committee. We have 10 or 12 members of African men in Alpha who are psychologists and psychiatrists and social workers and case managers who do the heavy lifting, this type of work, I think, in this area. That being said, we've been involved in this project now for over a year. I'm regularly excited about getting some young, new, talented persons to come and speak to you about key issues regarding brain health and mental health. And I'm very excited tonight to introduce a friend and colleague, Steve Starks, out of Houston, Texas. Steve Starks is a New Orleans guy. I'll share his own bio here briefly. Went to LSU for education and training. I know he completed some training at Baylor College of Medicine in Houston, kind of how he got to Texas. I actually met Steve Starks in our national organization of psychiatrists, the American Psychiatric Association. He was a young, rising, up-and-coming star, and he certainly has left a few tracks behind him as he moved very, very quickly and rise in leadership. He served as both as the deputy representative from the Black Caucus, so about 1,500 Black psychiatrists in the country, to the 48,000 overall psychiatrists in the country in the APA. Actually, I was the rep then, so we worked together closely for those 4 years. Then he moved to the role of the representative of the Black Caucus to the overall assembly of the APA. And he recently won an election, a very prominent election, I might add, as the recorder, or essentially the secretary of the AP Assembly. 300 members, really, of the elected legislative body of the organization. In his day work, Dr. Starks is a faculty member and an administrator at the New Med School at the University of Houston in Texas, where he leads curriculum work and development and education and training. So I'm very excited to have him today as a psychiatrist, very excited to have him as a board certified and trained geriatric psychiatrist, and really interested, I think, in the comments that that Dr. Starks will make, I think, to our audience going forward. That being said, Steve Starks, I'm going to give you the floor. Thanks for joining us tonight.
All right. Thank you so much, Dr. Bailey, for this invitation. Really kind of inspired and happy to be able to speak with you all tonight about something that's important and near and dear to my heart. I'm going to share my screen right now, and hopefully everybody can see this. Try this one more time here. Let's see. I'm just going to share my entire screen because it seems like something changed here. So hold on 1 second. All right. And Dr. Bailey, can everybody see that okay? I can't see you all, so hopefully
Yes, looks
okay.
good. Major neurocognitive disorders.
Sounds good. So what I'm going to be talking to you tonight as we lead into June, which is Alzheimer's and Brain Awareness Month, is to talk to you a little bit about dementia. You see this long title up here, Major Neurocognitive Disorder. So psychiatrists had reevaluated the term dementia, which was deemed not to be as accurate and actually a little bit stigmatizing. So we don't use the word dementia, although it's hard to really kind of change public sentiment and understanding. And as you can see, this word major neurocognitive disorders is pretty cumbersome and a challenge for many to say, even many professionals. But I think it is important, again, to have the foundation and background on that. Just again, a little bit about myself. I'm a geriatric psychiatrist by background and training. So trained at Baylor College of Medicine in Houston for my general psychiatry training. Did a clinical fellowship in geriatric psychiatry at Yale School of Medicine, and started my career actually in the VA system here in Houston, working in various geriatrics programs. So seeing older veterans in outpatient clinical settings, inpatient settings, hospital settings, seeing them at long-term care settings, nursing facilities, and also finally being a doctor who was able to do house call as a part of a home-based primary care team as a part of the VA, and then have gone on to do some policy work, again, in line with increasing awareness about the challenges that older adults face. Currently, as Dr. Bailey mentioned, I'm a clinical assistant professor at the Tillman J. Fertitta College of Medicine, and I'm also a Yale Posen Commonwealth Fund Fellow in Health Equity Leadership at the Yale School of Management. So I wanted to just have a general conversation with you all about dementia specifically, but just as a little bit of background, I wanted to go over just a basic understanding about how the brain itself works, so what it does. And so the work of the brain is to direct your movement, it's to process sensation, it's to regulate wakefulness and awareness, it helps to control emotions, and then manages those neurocognitive processes that we describe with dementia. And when patients always come to me with a memory concern, they always frame it that way. So I think I'm having a problem with my memory, and I like to kind of educate folks just about the term cognition itself, and I kind of simplify it. So cognition is what we're evaluating when we're evaluating dementia, and that's a combination of your memory, your ability to recall things, sometimes aligned with forgetfulness if it's not necessarily intact, but also those other thinking processes. And so today I'm going to try to hone in on those other thinking processes just to kind of give you an idea about what you might want to be concerned about with a loved one or a family member. I always like to preface this talk too. I mentioned I'm a geriatric psychiatrist, but I'm also the care partner of a parent with dementia. My father was diagnosed with dementia with Lewy Bodies about 3 years ago. And I think that's it's been important for a number of different reasons, but has actually been important in my own personal practice because I see it from a different lens now and recognize the challenge that many family members and friends of patients and individuals who live with dementia face. So what cognition is basically the mental action or process of acquiring knowledge and understanding through thought, through experience, and through the senses. And so think a little bit about how you got to this event tonight, right? Someone placed it on your calendar. You had to remember that it was tonight. You had to organize your time and day around it. So that's more than just memory that got you into the spot that you're in tonight, listening to me. So we'll kind of think through a little bit more about that when we think about challenges that folks face. I describe it in terms of, or it is described in terms of cognitive domains, so different areas of a person's memory and thinking processes. And I've just designed this simple mnemonic to define those types of domains. And my mnemonic is alarmed, and it kind of helps you think about maybe when you should be alarmed about your family member, your parents' memory and thinking processes. And so part of that cognition, that memory and thought process, is a person's affect, the A, or mood states. And so think a little bit for yourself about your own mood state. How do you feel right now in the moment? How did you feel earlier today? How did you feel, when you were in traffic earlier today, right? And so just to get an understanding about Cognition itself does entail those mood states, and so when we're looking at changes or differences in a person's mood states, that sometimes happens with life. You may know people who've experienced periods of major depression or anxiety. Think a little bit more, helps us to think a little bit more about cognitive processes. The next part of that is language. And so again, it's not just about your ability to speak, whether you speak one language or whether or not you're polyglot and speak multiple languages. But as you know, language takes different forms. So it's spoken, it's heard, it's written, it's understood. And so when we're thinking about language processes, we're trying to kind of analyze, how people express language, right, through output, through writing or speaking, or verbal, and also that receiving it, that receptive aspect of how you understand it, how you comprehend instructions, how you understand, symbols. There are lots of ways that language is expressed and received. And so that's something we also want to keep in mind when we think about dementia. Again, it's not just memory. We also want to think about attention, so an ability to sustain your focus. If I tell you don't think about, that pink elephant or purple elephant, right? It's kind of hard for you to kind of not to focus on that, not to be distracted by that. And you can think about general distractions in your day-to-day life. So whatever work that you engage in, how easy is it for you to kind of accomplish it from start to finish, or any other tasks that go on throughout your life. So it's important as we evaluate normal versus abnormal to think about a person's attention. We think about reasoning, right? So think about those important decisions you make, kind of those logical choices that you make in evaluating circumstances and situations. How do you go through that thought process and that reasoning process to kind of come up with a conclusion or your next step? So that's also part of our cognitive domains. Memory is the one that's easiest for people to kind of relate to and understand. So how can you remember names? Can you remember what you did yesterday? Can you remember that trip you took to Disney World with your family 20 years ago? And how much of those details are you able to remember? We often associate some challenges with short-term issues with memory. So not being able to remember what happened yesterday or what you ate for breakfast today, but some of those, memories from years ago might be a little bit more firmly implanted for a number of different reasons. Executive function, and I have this image of the maze here on the screen only because that's how complicated it is. So it kind of involves a lot of different aspects. So if you were to enter a maze or do a puzzle, right, you have to kind of sometimes retrace your steps, remember where you went wrong before, and kind of course correct in a sense. And so it's something a little bit more complicated, and you can sometimes think about that in some of the more complex work and actions that you do in daily life. And coming up with that last D in this particular mnemonic was a little bit of a challenge. So overall, it's visual spatial abilities, but it's basically deciphering design and direction. And so I have the image here of the car parked. Oftentimes, if we're at a crowded mall, people don't go to malls as much anymore for a number of different reasons, but think about yourself at a Walmart parking lot and how easy is it for you to find your car, for instance, on if you are going to some mall or going shopping on Black Friday, right? So again, that gives you a picture or an understanding about what we're looking for. Again, this is very oversimplified, but I think something that's a little bit easy to remember as we think about, what are we really looking for when we're looking for the challenges associated with dementia. And so again, just to reinforce, cognition is memory, but it's also those other thinking processes that we, come to relate to and understand through our thoughts, our experiences, and what we sense around us. And now I'm going to talk about a little bit about what's normal with age here, because we do know that just like other parts of your body, other organ systems change over time. Certain things are normal, but certain things are not normal. So the good news first, right? So your vocabulary actually may improve over time. Your general knowledge, again, may improve with time. And we can kind of define that or kind of frame that in terms of understanding wisdom. So a nice quote that I like is that apparently learning discernment is a lifelong process, and wisdom is hard won. So again, thinking a little bit about those as being positive. So those should actually improve over time. Here come the challenges, though. There may be a slower processing speed, so you may not be able to quite process things. My uncle recently gave me the example that he likes to play blackjack at the casinos, but this last time he went to Vegas, he knew he wasn't as quick as he was with kind of reading the game as he typically had been. And I like to kind of frame it in terms of this. So think of, having a file cabinet here with 2 drawers, comparing it to, what you store over a lifetime. The information is still there, but it might take you a little bit longer to find it in a particular drawer there. And so might slow you down. A person's attention tends to worsen over time. And so selective attention, like tuning out background. For instance, if you're in a loud, noisy restaurant and not always able to follow the conversation at your table, that might worsen. And then divided attention. So your ability as we age might be more difficult for you to multitask. And so talking on the phone while you're, maybe preparing a meal might kind of pour salt versus sugar into the bowl there. Again, that's kind of normal aging. Your procedural memory tends to be unchanged. And so procedures, we don't think about singing happy birthday as a procedure, but there is a type of memory there, or driving a vehicle, right? Those types of memory are relatively unchanged in times. Things like tying your shoes, you don't forget that. But your episodic, so remembering certain episodes of your life, and semantic memory may tend to worsen. So that autobiography might be a little bit different. In semantic memory, when it comes, it's just a group of SAT words that I never knew the meaning of, but your semantic memory for some words may be different. And naming things does tend to worsen over time. So I actually did a memory test on one time, and I couldn't find a word for this image, this trellis, and also had a little bit of trouble with, naming tongs. Sometimes, again, the name may come to you, but it may be a little slower to come to you, may worsen over time, and people may associate that with word finding difficulties with aging. And then construction does tend to worsen as well. And so you all might not shop at IKEA for a number of different reasons, but putting that drawer together and getting it to be an intact piece like you see before you today might be a little bit more challenging. Executive function may decline for new material. So if you have a new maze in front of you, new challenge, that might be a little bit difficult. But typically, you don't forget some other types of executive functioning, like interpreting things, the meanings of this image, for instance. What does this look like? Oh, people in glass houses shouldn't throw stones. Some of these are kind of culturally informed. But again, you don't sometimes forget those types of material. So again, just to reinforce it, now what's dementia instead? And so that has a specific definition within the fields of psychiatry and neurology, but overwhelming, we know that these are cognitive and behavioral symptoms that interfere with work or usual social activities. It has to represent a decline. It's not associated with delirium, which is kind of, a short-term kind of confusional state that fluctuates over time, and not associated with major psychiatric conditions, which sometimes, again, people may have problems with their function when they have a severe mental illness. And it must be detected and diagnosed by history taken from a patient. Sometimes, and most times, we don't always have access to a knowledgeable informant, but it is important to get another individual's perception, because as you might imagine, if someone has a memory problem, memory and thinking problem, you may want to have a reliable informant to get additional information, and we need some type of objective cognitive assessment. And so there might be some type of test or evaluation that needs to be done in addition to that. And dementia typically has to affect more than one cognitive domain. And so I listed those 7 for you before. Typically, we'll see that with more than one. I have this image here. So on that horizontal line, you see the years in terms of its time. And you see on the vertical axis here, the vertical line talks about cognitive function. We look up at the top, so that's kind of where we start off. And then as kind of things happen, we see that the normal solid line is normal aging. So that just reflects the normal declines that we see in cognition over time. But you see the dotted line here talks about a distinction and a difference in terms of the trajectory for a person who's developing dementia. So there is that preclinical stage, and that just means it's not picked up in a clinical setting by a professional, by a physician. There is that intermediate stage here you see here, which we won't talk about because that can be a little bit more complicated. That mild cognitive impairment is what that MCI stands for. And then kind of dementia is that ultimate stage there. So those are just showing you the different trajectories that decline does happen, but we do have to start to recognize when decline is not normal. And so for dementia, again, we talked a little bit about those objective cognitive assessments, and that can look different ways for different people. Oftentimes, it should entail, if it's happening in the clinical setting, when you're visiting a doctor, it should be some type of in-office screening, that mini mental state examination, or a Montreal cognitive assessment that got quite a bit of news when one of the former presidents was describing their score on that particular test, or the St. Louis University mental status examination. So it should be some objective measures where we can kind of compare what we know normally happens and what an individual might score. And there are more extensive cognitive assessments that should be performed additionally. So when my father first had his issues, I immediately wanted to get him to the neurologist, but also to see a neuropsychologist for more extensive testing. And neuropsychological testing often takes a number of hours, and it's has a great deal of accuracy in terms of really kind of distinguishing between what type of dementia one has. And so I always try to teach my students. Again, I work in undergraduate medical education where I teach medical students here in Houston. And so I try to give people to understand, again, what does cognition in day-to-day life look like? And so think about all the things that you do throughout the day and how, your cognition is impacted by these things, and how these things are impacted by cognition. So your work experiences, your ability to travel, shop, cook, clean, exercise, volunteer, the tennis you play, golf you play, basketball, praying, worship, socializing, managing your finances, doing your taxes, going out to the polls, driving, getting yourself organized, communicating with others, engaging with social media. All of these things take your cognition in order for you to complete those. And when we do evaluate it, we specifically for changes in dementia, we look at how individuals are functioning. We do that sometimes with these tools, these activities of daily living, and instrumental activities of daily living here. You can see the images kind of describe some of the basics with your ADLs, your ability to use the restroom, or feed yourself or dress yourself. And then the more extensive things with instrumental activities like doing chores around the household, or being able to do your own meal preparation, or being able to manage your medications. Those again take a higher level, and so dementia can impact individuals in these areas, and we as professionals evaluate it in distinct ways. Won't go with that. And so I always like to remind folks, because people always ask, do I have Alzheimer's or do I have dementia, right? So Alzheimer's disease is the most common form of dementia here in the United States. But remember, dementia or major neurocognitive disorders is the umbrella term, and several different causes of dementia exist. Alzheimer's is the most common, but we can also, individuals who have strokes and other kind of subtle, more silent strokes who have had changes in their mental status. Doctors may have kind of described that as vascular dementia. I kind of briefly shared with you my father's diagnosis of dementia with Lewy bodies that looks a little bit like Parkinson's disease in terms of the slowness of an individual's movements, their facial movements, or their walking, and also may sometimes have some visual illusions or distortions. Again, we won't go into details about all the other types that are out there. I guess Bruce Willis was recently diagnosed with aphasia as well. So there are different types that are out there. This is the most common, and so I always like to educate folks. So dementia is primarily an issue with memory. So we do know that it's an impairment or a problem in a person's ability to learn, new information or to recall recently learned information. And it can be insidious in its onset. We use that term, just means it kind of sneaks up on you. So it seems like, my grandmother was doing well one day, and then one day, I noticed she was getting lost and wandering outside, right? So it's very slow, it's very subtly noticeable, and even professionals kind of miss it at times. And we do know that it often is associated with a slow, gradual decline over time. It doesn't necessarily impact a person's life expectancy, but there can be challenges, obviously, as a result of that decline over time. We do know that there are certain risk factors for it. So lots of people ask me if they're at risk. And so sometimes that involves dementia in a close family member. And there are certain genes here. This ApoE is a certain type of susceptibility gene. And there are certain associated factors, lower levels of education, which I think is more kind of tied to what we're now looking at in terms of social drivers of health in our country. And we know as Black men, very impactful in terms of structural racism and other kind of factors. Female sex can sometimes be due to hormonal changes with time in women, might be also associated with the fact that women tend to live longer than men. That's a more distinct picture. And sometimes a history of head trauma can be associated with Alzheimer's disease and other forms of dementia. The image I have here, again, not trying to be too specific, more look at the pictures than the words on here, but it's just to show that it is a progressive disease over time. And so while it might impact a person's memory and thinking, we do know that it involves, as it kind of spreads throughout a person's brain, other functions. And so, things like movement or walking or ability to speak in late life and advanced dementia does change over time. And so I always like to remind folks about the opportunities to prepare for those changes and declines over time. And also because I think it's important to note here, and this again is another busy slide, but on the kind of horizontal line, the horizontal axis, we have time to diagnosis, and you'll see here that it describes, so 0 is at the point of diagnosis, and these are months before, so 40 is, around 3.5 years before and after, and on here is a list of psychiatric symptoms. The ones you may think about more common is paranoia, right? That certain individuals with dementia tend to have. Depression is very common. The y-axis, or that vertical axis here, shows the frequency of this pattern. And so what's important to recognize is that diagnosis oftentimes comes after other symptoms present themselves, and that happens for a number of different reasons. But we do know that a person's mood is also impacted by dementias as well, and Alzheimer's disease as well. And so thinking about, more increasingly anxious in old age when an individual hadn't been anxious, or a new onset of a major depressive sadness symptoms, or becoming more accusatory, or, thinking someone's stealing, or paranoid or suspicious that, an individual spouse might be cheating on them, or having hallucinations, or wandering, or more irritability. These psychiatric symptoms are very important because they also kind of sometimes dictate how well families are able to handle some of these challenges. And oftentimes that can kind of lead to nursing home placement and other types of issues that we have. And
Steve,
then
let me go ahead and jump in and ask a few items, because I think a few things are good and are coming to me in the chat. And
sure.
I'll mention three. And kind
of last slide here. I just want to quickly go through this.
You got one?
Yeah, this is the last one here. The last thing here is just early planning is incredibly important. Again, you want to discuss choices and decisions with your family. Financial planning, planning again for firearm safety. That's always first. Advanced directives. How a person wants to live in old age. Are they open to a nursing facility and home care? Trying to maintain dignity, of course, and safe choices. So we do want to make sure a person is able to make kind of relevant and independent choices for themselves with their family. Again, sometimes that gets complicated, but some challenging issues like driving, taking the keys from someone, or taking their weapon can be a big challenge. And finally, it of course takes a village to do this. And so we can talk a little bit more in our discussion about how you kind of coordinate those resources, good primary care, specialty care, if appropriate. FDA-approved medications can be helpful and tolerable, but they're mostly in terms of kind of disease or symptomatic treatments. We don't have any disease-modifying treatments that reverse changes, and then I will conclude. So thank you for that. Yes, happy to start this discussion now.
No, excellent. And I didn't mean to rush you at all. I didn't know you were actually on to the next to the last slide. I was going to mention a couple of things that are coming to me in the chat, and we certainly can move into the question and answer. So one thing, I think that the initial acronym of ALARM was very timely. One that I think many have not seen. I was going to ask you to kind of go through that again, because we do have some persons who come on after the beginning, and I think that'll kind of make the discussion a little bit more informed if they get a good rubric of that ALARM acronym. And then I'll actually talk a little bit more about the term Alzheimer's dementia. You mentioned it, I think, very accurately, but I think you and I both know that it's just such an overused term in our society that many people may still need to hear maybe more than once that all dementia is not Alzheimer's, what some of the differences are. I thought your point was correct in regards to the fact that many will have a stroke and have more of a cardiovascular-based problem. I want to give you some time to kind of discuss that in more length. To some questions coming to me in the chat on those two issues.
Okay. Sounds good. So I'll pull that acronym and run through that list just one more time here, and happy to share that as well. I need to get that published at some point in time, but let me share my screen here. You can see that.
That's a good acronym.
There we go.
I love the way you worked out visual spatial abilities. That was good.
Yes, yeah. So again, when we're talking about, so to your point earlier on, and I'll have that broader discussion just on the front page here. So our new term for dementia is major neurocognitive disorder. I think that's a branding issue. I can't sell that to patients at all. I don't like saying it myself, but I do like folks to be informed. But when we do think about this term, major neurocognitive disorders or dementia, remember that that is just an umbrella term. And so when I see my, for your audience to be aware of it, right, so most people don't have access when they're diagnosed with dementia to a neurologist, cognitive neurologist, and they certainly probably don't have access to geriatric psychiatrists. We're few and far between, and so you oftentimes don't have a subspecialist that is making this diagnosis. The challenges that I sometimes see from my friends and colleagues in primary care who put on the term dementia is that they don't look for the underlying cause. And so whenever we're thinking about someone has dementia, I'm always questioning what is the cause. And why am I asking that? Because it does make a difference. It makes a difference in terms of the treatments that we offer, the medications that we use, the ones that we use most often are Alzheimer's medications and drugs, but they don't always work in some of the other forms of dementia. And so I'll briefly kind of just hit a list here. So we talk about Alzheimer's disease as being the most common. Second most common, depending on how you look at it, is vascular dementia. So those are the types that are associated with those silent, subtle strokes. And oftentimes we need a brain scan of some sort, an MRI, to kind of evaluate that. And there are other findings that we can look at from a physical exam and a person's history of high blood pressure or heart disease that are oftentimes associated with that. So vascular dementia, like I mentioned, my father has dementia with Lewy bodies, and that's something that's also incredibly common. So that is a dementia that's associated with hallucinations, that's associated with certain types of Parkinson symptoms. We describe that as Parkinsonism, so slow movements and other aspects. We do also know that Parkinson's disease can have a dementia associated with it. Parkinson's disease dementia. We talk a little bit about other progressive illnesses like Pick's disease or frontotemporal dementia. So just to have the audience understand that it is important, again, for your doctor to clearly define what it is. And if they do say it's the Alzheimer's disease, right, you want to ask why. And as I mentioned in my talk, it's primarily a problem with memory and what we describe as an amnestic disease. And many of those other types that are listed fall in the bucket of non-amnestic. So the vascular dementia or dementia with Lewy bodies. So for instance, my dad's memory is actually pretty, it's off, but it's stronger than most with Alzheimer's disease. But he has more trouble, finding, getting himself from, the bathroom in his home back to his bedroom, right? So he has the other issues. And so I'll quickly run through that list here that we talked about before of that mnemonic. So again, we're looking at affect. Some of our dementias have changes in our mood states, like the frontotemporal dementias. Some of them are more impactful on our language or ability to speak for various reasons. Some of them adjust and have problems with our ability to sustain focus and attention. So are you able to, start a task and complete it all the way to the very end? Sometimes reasoning might be off. And so if it's much more difficult, if you're an accountant and it's now difficult for you even to maybe kind of do your own personal taxes, right? That can sometimes be an issue in terms of reasoning. Memory, we kind of, talk about to death. Executive function, again, a little bit more complicated because it's a little bit multifaceted. And then finally, those visual spatial abilities, deciphering design and direction. And so those assessments that we talked about, the in-office tests that you can get, the neuropsychological testing that you get, and even what you witness at home. So I often take very kind of copious notes when I'm running through the list of these 7 domains with the patient and the person that's accompanying with them, just to see, they might not have noticed it before or when it started, right? Sometimes you think things have only been going on for, 2 months, and then the more questions you ask, you notice, okay, well, maybe they actually started to have challenges a year and a half ago. I remember someone called, or at work, there was a complaint that their coworker made about a decision that they made on the job. So sometimes it can be quite subtle to pick up on.
It's a tremendous point. I think that the idea that the problem is multidimensional, I think, is important. It also kind of points out that it can gradually grow over time. I've always thought that some people struggle if they think that it's only memory. So there's also the slide that showed that cognition is really both memory and thinking. Many people tend, it seems to me, to accept the memory piece and kind of make a joke about it. And they say, that's just my Alzheimer's or whatever, but really miss the fact that there are a variety of aspects of thinking that begin to change. One example is that's why folks have trouble driving. And sometimes folks will accept that the memory is not optimal, but then they'll fight you on driving, not realizing that others around them consider that driving is beginning to be impaired. So talk a little bit about what people in the audience should be thinking about with their own relatives, for example, or others, as you try to communicate with someone, maybe developing some of these symptoms, and you want to do it in a way where it won't be antagonistic, but there you can be partners in their overall assistance so that they don't have a rapid decline, but that you can actually work with them and maintain some functionality.
That's a good point. Now, I'll talk a little bit about that because that's the challenge that I often get with family members or with friends or colleagues who call me to describe their challenges with what to do when they see something that's going wrong, right? And so how do you get it? That individual might not tell their doctor, right, that they're having a problem with their memory and their thinking because of stigma or because they don't have the insight to do it. I can tell my dad even now that, he can't drive a vehicle and that he was having issues paying for his real estate taxes and was quite behind on that, but he doesn't believe in it and he won't share it. So what I always encourage people to do is think about who your partners are, right? So think about your family dynamics. If that individual can't hear it from you, can they hear it from your brother, your cousin? Can they hear it from their brother, cousin, or can they hear it from a physician? Can you, oftentimes in practice, right, we know that there are privacy laws that, dictate what can be communicated to you about your loved one's health conditions, but you can always pick up the phone and call your family member or friend's primary care doctor and say, this is what I see, right? I know you can't tell me about their care or their treatment, but this is what I see. And is it possible for you to do some type of in-office assessment or to refer them to a neurologist or to get that, brain imaging they may need to look further at those issues? So trying to come up with it. And I always say it is important to think about, because I do think, especially in our communities, we assume that dementia is sometimes normal. I've been in situations where someone brings their relative to me and it's obviously that they have dementia, but they just assume that's normal and And sometimes that individual could be in an unsafe circumstance and maybe living at home alone. And then my alarms are raised, and I'm thinking about, the fact that they say they're still cooking, but they know they left the stove on at one point in time, or several challenges there. And so I think for us particularly is knowing when to intervene. But I do think that sometimes our family structures are broken down such that we don't always have the resources, financial resources, to support this. And again, it can be quite costly. And we can talk a little bit about those challenges too, about how do you find the right kind of care and resources for your loved one.
That's a good point. I also really liked your slide that showed the transition towards some form of decline cognitively over time. I thought it was well developed. It shows that there's normal decline. You call it normal aging in the the solid bar, but then with MCI or mild cognitive impairment, which I've always read, some studies have shown may occur more so in African Americans than in other groups. And with dementia, you get a much more rapid decline. So I think that's part of the challenge. Some may want to think that either the relative is normal or they got dementia, and miss the fact that probably most of us have something in the middle. And next, I want you to address the kind of things we might be able to do to moderate the rapid decline.
Yeah, and I'll show that slide here again as I answer your question there, because that's a great point. Let's see if I can get it up. I'll just share my.
I'm a psychiatrist, so they pay me to ask good questions.
Yes. Can you see that slide? Okay, yeah. So this is that description, right? And so when we are, like I mentioned before, we're looking at years on that horizontal line at the bottom. So these are changes over time that's reflected. And then that vertical line is cognitive function, the arrow pointing down, because again, we are talking about changes. That solid line there being what we describe as normal aging, age-related cognitive decline, right? So all the normal things. And then this bar before. And so to your point, I will dive a little bit more deep into it and describe like that preclinical. So we do know, and I'll push Alzheimer's, dementia of Alzheimer's type to the forefront for this particular conversation. So don't really associate that with the rest. So as I mentioned before, and as you all know, that's a problem mostly with memory. Again, it can encompass multiple and has to at least encompass two, typically memory and language. But again, mostly a problem with a person's memory and short-term memory. And so what does that look like, right? So when we talk about a short-term memory complaint, that's someone asking you, now where'd you get that shirt from? Right? And 5 minutes later, in that same visit, I really like your shirt. Where'd you get that shirt from? Right. So now that's a more concern for dementia, right? In that case, but that's just one kind of example. And so when we talk about memory, I always like to kind of break down what that is, and especially to students, because people don't always ask all the questions, right, when it pertains to memory. So think about what you remember in a given day. So do you misplace items more than usual, right? Keys, phone, wallet, right? And there are other reasons why you can misplace things. You might have a lot going on in your life, being inattentive. Sometimes I'm misplacing items, but are you misplacing it more than usual, right? That's one aspect of it. Are you able to remember names, right? Names of, celebrities, sports figures, right? Different people have different types of names that they remember, different things that they're attuned to, right? So that's one aspect. But, what about people who are close to you? So that might be different. It might be harder to remember your great grandchildren's, their names, right? But you might be more hold on tighter to, your spouse's name or your children's name. So we can think about that, or, thinking about your full group of friends or fraternity brothers, right? Remembering those names. Think about remembering important dates. So forgetting birthdays, skipping birthdays, right? Remembering to take your medications, remembering to eat, remembering your appointments. And so when we talk about memory, sometimes we break it down into a number of categories there. And so for me as a physician, and those physicians in the room, if your patient is missing appointments or forgetting to take their medications, or at least you're getting that based on, with some of their health incomes, their blood pressure measurements, or their hemoglobin A1C, or their blood glucose levels are starting to change, you should start to think a little bit closer, are folks remembering these things? And so we talk about that preclinical factor or facet of Alzheimer's disease specifically. And we do know that Alzheimer's disease, at least the disease that we can see in the brain, develops 2 to 3 decades before onset. And so if we think about that, that's, in an individual's 30s, 40s, 50s, right, when that starts to develop. And so, it's there, right? Doesn't always lend to disease or a clinical diagnosis or symptoms or problems in old age, but most likely it will. And so we do know that what can you do early on, right? So it's all the basics you always hear about: increased physical activity and exercise, monitoring your diet, controlling your blood pressure, your blood glucose if you got diabetes. So all those things are important to either build what we describe as cognitive reserve or brain reserve. Again, the question is sometimes out about that. Sometimes people talk about types of diets, which can impact it. Mediterranean diet, other types. Sometimes people talk about types of exercise that might be important for that. So that's kind of the preclinical phase. Doing the best that you can do to optimize your health is always going to be important, and diversifying the types of activities that you do. On the very end of that spectrum, again, we have dementia, but you mentioned, Dr. Bailey, mild cognitive impairment, that intermediate phase. And what we do know, at least with an amnestic MCI, so the MCI associated with Alzheimer's disease, is that individuals who have an amnestic mild cognitive impairment in old age tend to have increased risk of about maybe 3 to 10% per year after their diagnosis of mild cognitive impairment. And so there is a likelihood in many individuals that they will develop dementia of Alzheimer's type over time. And again, there is some variability there, and we do talk about the treatments that we have available. Some doctors actually start to prescribe medication for MCI, even though it's not indicated. And when I say indicated, the Food and Drug Administration only approves it in Alzheimer's dementia, but there are times when we do start it when we're pretty sure and certain that someone has an amnestic MCI, to be specific. As you might have heard about the newer big drug studies that look at types of monoclonal antibodies, and there was a big drug, Aduhelm or aducanumab, that was released and has been quite controversial because of its cost and because some folks aren't sure if it really helps out. Those are purported to be a disease-modifying type of treatments, and hopefully we get one soon. But sometimes there's not really a lot that can be done to prevent the decline, and we're still looking and analyzing that. And I just want to mention again, for those who may have missed the conversation about MCI, I didn't want to talk about it in detail, but that's when we do see that there is an objective decline or change in someone's cognitive status, but functionally they seem to be doing good. So I can still, maintaining my volunteer work, still able to take care of my household, do my chores. So there we have the cognitive part that's kind of deranged and off, but we still have good daily functioning. And dementia, of course, is when that cognitive function starts to impact your daily function and daily activities.
Yeah, I really appreciate the analogy and the description, because I definitely think that, the 3 or 4 issues in play, I think, for our audience. One, I think we all know that we live in an era and a time of people living longer. In 1900, the average American, went to, heaven, we'll say, at age 49 was the average, or 50. 100 years later, by year 2000, it was age 75. So we definitely have increased the length of life over time in general. Good medicine, public health measures, better nutrition, antibiotics, if you will, been attributed to a lot of that. I do think that the next century, in the time we're in now, preventative measures for these concerns maybe the next horizontal frontier for how people are going to live longer, but also how they're going to live better, with less morbidity and more functionality. So many would argue that geriatric psychiatrists, like you, my friend, are going to be at the top of the list of value, and people learning to go to persons like yourself early and ask, what can I do? You mentioned diet earlier. There's some issues regarding medications. I'm sure other people in the audience are interested in what other kind of things can they do so that they can think clearer, for a longer period of time. And I love your point about be able to function longer. Because if you can imagine, that's a great slide. The key would be you want to live forever, but you want to decrease the time when that bend starts, and decrease, I think, the acuity of the bend when there's more functional, cognitive, and thinking related decline.
Yeah. And I'm going to share my screen because I see someone did ask again about dementia. So I did have a slide that I deleted before, but I'll add about the different types. And so let me I'll answer your question, but I also can do that while I.
Oh, go ahead. I think that the dementia issue is the one that people really want to hear about. So that's
absolutely good. Yeah. So I'll talk about that in the prevention aspects. Let me again share my entire screen here. And let's see. Can you see that particular slide on neurocognitive disorders pretty well?
Yes.
Okay, so I'm just pulling them up here. So when we talk about it, this language here is a little much, but these someone asks is Alzheimer's dementia. So again, I'll just reiterate that these are different types of dementia here. And so again, I mentioned the new term is major neurocognitive disorder. I've abbreviated here major NCD. And these are the different subtypes, and etiologies just means what causes it. Subtypes is the subtype of it. And so here is a more comprehensive list of it. So we can have it that it's due to Alzheimer's disease. Again, I mentioned that's most common. It can be vascular. It can be with Lewy bodies. Dementia can be due to Parkinson's disease. It can be frontotemporal dementia. It can be due to a past history of traumatic brain injury. It can be due to HIV infection. There are certain types of dementia, dementias that are associated with HIV. It can be due to other types of prion disease. That's just a type of protein. It can be due to other medical conditions. And to really throw a mix in it, right, it can be multiple, right? So there are people who have both vascular and Alzheimer's type, both Parkinson's and Alzheimer's type. So that's the full list. And so again, just hitting on the point that it's important for you to be aware of which one is it, because treatment looks a little bit different and their progression looks different in terms of their timeline or in terms of the other impacts. And how I typically break it down is by their motor symptoms. So which one of these cause a change in a person's ability to move, walk, types of movements, extra movements like a tremor, for instance, or slow movements, or different types of changes in a person's ability to ambulate or walk. And then I also break it down into the different types of psychiatric symptoms associated with it, because they're oftentimes different. So we do know that people who have vascular dementia, about a third of them might have a pretty severe or moderate or severe depression associated with it. And so I oftentimes categorize each one of these different subtypes by what type of psychiatric symptoms they have, which ones have hallucinations, where you hear things or see things, which ones have paranoia, which ones might make you more irritable. So motor symptoms, psychiatric symptoms, and finally, like we talked about in a lot thus far, is the type of cognitive symptoms, language versus memory, et cetera. And then again, to your question about what kind of can be done earlier on, again, it's always going to be that basic thing. So for how I look at it is think about your current health status, or the health status of the ones that you love. If they have hypertension, if they have diabetes, again, there are associations with different types of dementia. So you want to make sure you can do your best to optimize and are under control with those, and work with your doctor to be able to do that. And I know sometimes we as Black people have challenges with receiving the type of care that we need to be from our doctors. If you have access to switch to someone who is listening to you and responsive to you and working with you, you're able to do that. Or if you feel like you can advocate for yourself in those one-on-one, maybe 15 or 20-minute visits, I know it's a challenge, try to hit hard on the fact that you want your health indicators in control. Same thing again when it comes to physical activity and exercise. That should be a regular occurrence. There's some studies again to show that even relatively kind of moderate exercise, so just walking for more than 30 minutes 5 days out of the week can be helpful in terms of future cognitive challenges that an individual might face. Certain types of sports can be helpful. So sports like tennis, where there's kind of that interaction and play and back and forth, can kind of be helpful, because again, if you think about the role or the actions of tennis, right, there are lots of different cognitive domains that are involved in that type of gameplay. Increasing the types of hobbies and learning new things, so reading more books or new books, or trying different games or that you have to your bill, trying to learn a new language. Those things are still possible. It might take you longer. You might never reach proficiency, but those type of things can also be helpful in preventing it. But I always like to, stopping smoking, number one. I don't know why it took me so long to get to tobacco cessation. That's number one. So if you're doing that, get your patches, get your gum, get your Chantix or varenicline, a medication that we know can help people quit smoking. Is going to be the biggest impact, especially if you are predisposed to a dementia. We know that does not help your just like it doesn't help the arteries and blood vessels of your heart. Don't help the ones that go to your brain either. So thinking
That's a good point. I think that, the reality is the brain is an organ like others: heart, lung, kidney, pancreas. And probably not this audience, because I think it's a very informed audience, but I just think many lay people at times don't tend to think that way. We think that the brain somehow is different, and you have what you're going to have, but it's not going to change. You can't make things better. You mentioned stopping smoking. I think decreasing and not stopping the typical use of alcohol, which can sort of kill brain cells, can be neurotoxic, if you will. Also, it's got to be very, very important. People think of the big things like a blow to the head, a boxer, Muhammad Ali, and the like. But I think there are many small things we might do that can also be adverse and problematic. I love your point, though, about, I think, some positive, proactive activities. You mentioned, games or whatever. I had a grandmother who I thought was sharp as a tack till she hit her 95th birthday, and she did crossword puzzles every day, it seemed like, of her life, at least the last, couple decades that I was aware of, much of her adult life. And I think that those kind of things are exercise of the brain that can be very helpful. Anecdotally, I think there's a lot to be said for them. Mention if you have any comments about empirical data, because I think people are very interested in being aware, because there's a lot of folks on who are probably my age, in the 50s, not necessarily your age, in the 30s, we'll say, if you will. And you begin to think about these things, because the reality is you already begin to have some early exposure to a little, challenge with memory at times, and things that, your executive function isn't quite as sharp as it used to be. So people begin to appreciate that these things are happening. And I think some active, proactive things to be engaged in will be very helpful.
Yeah. The other thing I'll add to that too, because just in our normal evaluation, we're also looking at a person's, vitamins and whether or not they're, need for supplementation. There have been studies that look at a number of different vitamins, and vitamins are certainly helpful. Vitamin B12, vitamin D, and old age for a number of other different reasons. But we've looked at things like vitamin E, vitamin C for use, and there's evidence plus or minus for those. Those can be helpful, particularly in Black communities for a number of different reasons. So I think those things again are something we can add to our arsenal. Again, good nutrition is foundational, but just a reminder there that there are times where vitamin supplements over the counter can be helpful as well. And I did want to shift gears, because we did talk about things to prevent it. I do want to be mindful, though, that some people on here are probably, maybe care partners, caregivers, family members, trying to kind of figure out how to navigate that. And so what do you do when your loved one does have a symptom? I do, to your point about maybe the differences that happen in terms of the healthcare system, which patients have access to it. So I can't remember if I stated it before, but we do know that Black Americans are, in some instances, 1.5 times to 2 times as likely to have Alzheimer's disease. So we do know that the incidence or prevalence is higher amongst our communities. I think that goes in line. Folks are still trying to figure out why, right? I think that's still in line with everything that we know about the structural, systemic, and can everybody still hear me? I see Dr. Bailey is out of the chat.
I'm here. Can you hear me?
Okay, I can hear you. Okay, I just wanted to make sure you didn't fall off. So we do know that the incidence is prevalent and more prevalent in our communities, and oftentimes we don't have access to the same types of treatment, the same medications, the same clinical research trials and studies, the same caregiver support for other individuals. And so I do think it is prudent for us to have real conversations about medications. And we do know, again, like I mentioned, that there are no disease-modifying medications that actually change, stop, or halt the progression of Alzheimer's disease with old age. But we do know that the medications that are effective for symptomatic management do reduce some of the other challenges associated with it. And so I do encourage folks to try to get early access to those medications. We're also oftentimes diagnosed at a later stage of the illness. So typically we categorize it in terms of mild symptoms, moderate symptoms, and severe or more advanced dementias. And again, our interactions with medical systems are typically at the end of it. And so I'm, again, trying to encourage folks to get early access, but there are a number of challenges to that. And so we have to be mindful about that. And then lastly, I just want to be mindful that there is a significant cost. So there are to taking care of an individual and a loved one. We know that they oftentimes need more caregiving needs, and so that oftentimes means a family member, and oftentimes in our communities, a daughter or a female relative who is leaving the workforce to full-time, to engage full-time in the care of that individual, and that oftentimes has a lot of impact on that individual. And some of you may be, like I mentioned, care partners, and maybe dealing with your own stress, anxiety about that, particularly in this past couple of years in the midst of this pandemic, when folks really were facing a significant amount of challenges. There are basic resources out there. The Alzheimer's disease does offer free resources. So there are care consultants that will work with you individually. You can pick up the phone. The number's there 24/7. So if you have an issue in the middle of the night, someone's, combative or anxious, and you don't know what to do, and you definitely, as Black men, don't want to call the police, right? So you can kind of engage with someone to help you with that journey. And then also kind of thinking about the financial burden of it. So the cost of having an in-home caregiver is extraordinary. The cost of an assisted living facility, and oftentimes we don't have the wealth to really kind of manage some of those needs, and so it can be quite complicated. But again, I always try to connect folks with the Alzheimer's Association early on because there are a tremendous amount of resources, and they oftentimes actually have culturally informed resources as well, given the challenges that our communities face. So I'll share that link in the chat, but happy to talk more about that as well.
Tremendous points. I'm just looking for an additional question in the chat. I think that Brother Sterling is asking at 7:02 about coming on, so we're going to bring him on here shortly. I would just simply say I think the discussion tonight has been just outstanding. I thank you so much, my good friend Steve Starks, for really a timely and well delineated and a very thoughtful and comprehensive discussion. I'm particularly sensitive to, I think, 3 or 4 points. One, first and foremost, it's about education and information, and that's what General President Willis Lonser's goal has been, I think, in putting this together. And I think Surgeon General Jeffrey Sterling has done an excellent job really organizing, I think, a series of topics that I think grow upon one another. So I think it was actually timely for us to have this discussion. I know we're, as you said, June is Brain Awareness Month. I think secondly, though, the reality is many people have a superficial understanding of some of the issues we discuss in medicine, but I think bridging the gap and bringing, I think, the information process to a level of that's much more practical and pragmatic is timely, and really good educators can do that. And I think you show yourself to be an outstanding educator today, and I'm sure they're happy to have you at University of Houston. If you get ready to come back to LSU at any point, just know that there's a place for you at LSU. I think the third thing that I also comment on is I think that this speaks to, I think, things that families can do as we love on our relatives. I mentioned my 95-year-old grandmother. She went to heaven at age 95 about 5 years ago. My mom now is 81, pushing 82. We all, this will be in our lives, our circumstance. I appreciate your comments about your own father, if you will. And good familying is about loving on our relatives and being able to help them as these challenges occur. I think the comments you made tonight, I think remarkably go a long way to giving people the kind of tools that they need to be mindful and helpful, because I imagine it's very scary and can lead to some degree of fear and anxiety and angst by someone as they may get older and lose some of these capacities and have some of these challenges. So I think all timely and well spirit kind of going forward. I think that thanks, no problem. So we're going to go ahead and move forward. What I did want to end with tonight, I think we said it early on before we got on the big group, but we generally introduced ourselves, and I didn't comment that I actually came in Alpha Phi Alpha via Alpha Rho undergraduate chapter at Morehouse College in spring of '84. Now I'm in New Orleans, and we actually just started a new chapter midway between New Orleans, which is Sigma Lambda, and Baton Rouge. It's called Omicron Psi Lambda grad chapter in La Place, Louisiana. I'm in this role of associate founding member, and I'm just very thankful and appreciative, I think, of that group of brothers to be engaged and support what we're doing tonight. I see some of the information in the chat, and particularly thankful, I think, for Brother President Jay Watson for, I think, his leadership. So I do think that we really try to give a shout out on these discussions, the different chapters around the country who participate, who watch and who listen, and some of the comments, Dr. Starks, excuse me, have been very positive about your comments tonight. So that being said, Ron Bailey, we're going to be signing off. I'm going to go to Surgeon General, Brother Dr. Jeff Sterling, and give him a chance for any closing comments.
Thank you so much, Dr. Starks and Deputy Surgeon General Bailey. I don't want you guys to leave just yet, because we never have enough time in these conversations, and they're just wonderfully poignant and informative. These Surgeon General Initiative health webinars in general are meant to inform you and to empower you. Unfortunately, that often involves discussing healthcare disparities in the African American community. I don't think it came out, but Black participants in Alzheimer's disease research studies actually indicate that we get diagnosed with Alzheimer's and related diseases 35% less than white participants, when we know that national statistics say that Blacks are about twice as likely than whites to develop dementias. Okay, so let me say that again. Even though we develop these diseases at a much higher rate, we actually end up being diagnosed at a lower rate. As is often the case in these webinars, we then need to talk about how we can empower ourselves to both avoid these conditions and to know the signs so that we can have meaningful conversations with our healthcare providers to get diagnosed and appropriately treated. I want to remember the wonderful slide that Dr. Starks put up showing the difference in the rate of mental decline during normal aging versus the types of abnormal cognitive declines that occur in conditions such as Alzheimer's. Although many of you may be watching this webinar with a focus on your parents or other elderly loved ones, I would ask you all to begin taking inventory of your own brain health. Seek out means to maintain good overall health as a means of maintaining good mental health. If you've been following these talks, you pretty much know the routine, but I want to focus on 5 basic principles that in general will keep your brain healthy. It's simple stuff, right? Let's talk about diet to a certain degree. Reduce your fat and cholesterol intake. Simple step. Consider using olive oil instead of saturated fats. Bake or grill your foods instead of frying them. That makes a direct difference to your brain health. Similarly, there are specific foods that are known to protect and to promote brain health. Very simply put, fruits, vegetables, nuts, and fish. We're not going to get into explicit detail, but just remember, there are healthy foods. You know what they are. Start doing these things now, and it will hold you over the course of time. Now, there are also brain healthy vitamins. This is a conversation about which you should be aware. Foods that are strong in vitamins E, C, B12, and folate actually appear to be important in lowering your risk of developing Alzheimer's. It shouldn't come as any surprise that the foods I mentioned before come high in those vitamins. So think about that. And of course, activity. You call it exercise, I'll call it activity. Blood flow is life. And doing things that maintain good blood flow to your brain will actually continue to promote good brain health as well. And finally, be social, and be a lifelong learner. You've heard this many different times before. There are things that you can do that represent brain exercise, puzzles, crosswords, learning a language, playing a musical instrument. These are very simple things that you can do to exercise your brain. Be empowered. Don't just be a passive consumer of activities. As a matter of fact, being passive is some of the worst things you can do for your brain. We used to call television the boob tube back in the day because you really weren't interacting with the medium to stimulate your brain in any meaningful way. Cut that out. Quit being a couch potato. So in short, hopefully you'll rewind this and look at both the information we provided and some of the tips that we've given you that can empower you. That's what we're trying to do here. That's what we want you to do. Own your brain health, own the rest of your life. And thank you for joining us this evening. Again, thank you, Dr. Sparks and Brother Deputy Surgeon General Bailey. And to the audience, we will see you in 2 weeks for a discussion on dental health. And until then, be safe, be well, be healthy. God bless and good night.
Good night, everybody. Good job.